Thanks for being awake with us this morning. I think I'm awake. I want to thank the Department of Gerontology and all of you for being here today and being in TV land to listen to me. My name is Dr. Gary L. Penny, MD. I'm a psychiatrist practicing here in San Antonio in private practice, dealing with depression, anxiety disorders, and also run, at least at present, one of the city's only sexual therapy clinics. So I treat a great variety of things. I take great pride in trying to get all my patients well. I took great pride also in my training, which actually was here in this health science center back in the late 80s and early 90s. And since that time, I've maintained a clinical assistantship here with the school. And again, I consider it a great honor to be able to come and speak at my alma mater again. And hopefully I'll be able to teach you something. Hopefully you'll hear something you haven't heard before. Hopefully I'll solidify some concepts you have heard before. And hopefully too, I'll raise some questions. I have approximately 40 overheads to run through, so if you have questions, if you would please hold them till the end so that I can get through them. I understand I have about 40 to 50 minutes to do this, because I want to make sure that I'll leave plenty of time for questions. So let's get started. Well, the topic that I was asked to talk about today was anxiety and mood disorders in older patients, and that's a very broad topic. In fact, it took me several days to narrow this topic down to one that I felt like I could do justice to, so that I just wasn't all over the place or just talk about one thing. It's a very broad topic. And needless to say, elderly persons, older persons, just like young persons, can get sick. And my job, again, as a clinician, is to make people well. Anxiety and mood disorders are the main things that I treat in my practice every day. And I'm sure you in the health professions deal with this a lot, too, in your own clinical sites. The objectives today are these: to diagnose and track recovery from anxiety and depression, to understand the neuropharmacology of anxiety and mood disorders, to understand modern treatment modalities, and to also rationally select treatment for whatever ailment afflicts our patients. It's important to remember right off the bat that what I treat in my office, as well as who you treat at the various sites, is not just a fleeting problem. It's important to remember that clinical syndromes like anxiety and depression are not just weakness of character. They're not weakness of character. And they're not just a transient phenomenon. Because worry, just like sadness, is somewhat and unfortunately an expected part of life. However, clinical anxiety and depression is not. Grief, again, is an unfortunate aspect of our lives, death of loved ones, loss of things very dear to us. But again, sadness and grief doesn't equal depression, just like everyday worry does not equal clinical anxiety, and we must keep that in mind. And it's very important to keep this in mind in light of what happened on 9/11. Many Americans have been affected by this tragedy. I've had more persons come into my office having had this event stir up more anxiety and depression in them than I would normally expect in the course of normal human endeavors. These illnesses too of anxiety and depression are definitely caused at times by tragic events like 9/11. I was mentioning to one of the staff this morning that one of the drug representatives who calls on me at the office couldn't be here today because her daughter was killed in a motor vehicle accident. Again, extreme tragedy. Definitely be grieving the loss of that, same as those who lost loved ones in the 9/11 events. These events can lend themselves and should lend themselves again to grief. You can also have anxiety over what's happened. Hopefully, neither my drug rep friend will have clinical depression or clinical anxiety from it, but again, she's going to have to work through the grief process. That is normal. And I hope that we as a nation can get through the events of 9/11. I think we're healing. I think the Olympics and other things are helping us with this. We are getting through. So what causes anxiety and depression? Many things. Some people are kind of born with it. I have some patients who come to the office and say, "Doc, I woke up a week ago nervous and depressed. Help me out." What happened to you? Nothing. Have a good job, a great family. Something's going on. Help me explain it. Well, has anyone in your family ever had this before? Yeah, my mother had it. And my grandmother was nervous. In fact, my great-grandmother, we think she took her life. What was going on with your grandmother? Oh, she was a great woman. She just was kind of that way. That shows the importance of genetics. Personality factors, inbred patterns of behavior affect humans just like they affect other animals. Temperament. is an element of that. Obviously, environmental factors, again, tragedies like the 9/11 events, car accidents like the death of my friend's daughter. Biochemical factors that can be brought upon by other illnesses. And in any of these factors of genetics and personality can affect the brain and the body, which in the long haul does cause changes in biochemistry. And when you assess people, you have to think of people, again, somewhat in the realms of what I just showed about genetics and personality. And when you do that, a paradigm comes to mind that was or has been around for a long time, and I was actually taught it in my own medical training, called the Biopsychosocial Model, in which you have the biological side of a person, the psychological side of a person, and the social, and you have to assess all three of these and see how strong a person is in all three of these to decide where do you need to help them. If psychologically they're very strong, maybe they don't need psychotherapy. If they have a great job, a great church life, maybe they don't need much help in that realm. But biologically, if their mother was depressed and they're depressed, maybe they just need medication. Or they have uncontrolled diabetes, or perhaps undiagnosed thyroid disease. So you work on the biology, as well as psychology if need be, as well as sociology, to help a person be whole. In fact, it's looking at those multiple realms that we in psychiatry, and particularly through the American Psychiatric Association, developed a multi-axial format for us to really look at a person in their whole. Axis 1 is determined, or has been determined to be, clinical psychiatric disorders like major depression, panic attacks, schizophrenia. Axis 2 looks at personality issues, as well as mental retardation. Axis 3 are our general medical conditions like diabetes, heart trouble, strokes, you name it. Axis 4 are psychosocial problems, loss of job, loss of marriage, death of child. And finally, the fifth axis is one of global assessment, where you tag a number to how well you think the person is doing. But again, in the realm of psychiatry, in my practice as a psychiatrist, I think of people globally. And I try and help them out with all of these areas that I can, so that I don't leave a stone unturned and put them at risk to either be sick or not get well. When you look at these different areas, different treatments have to be rendered, and it just makes sense. Pharmacotherapy, medicines for depression, diabetes, heart trouble. Psychotherapy to help people with personality issues, interpersonal issues, relaxation techniques, there's many. Social therapy, that's along the lines of helping them find work, get back to school, take care of the family. Most people I find when they need help, though, they need a combination of all of these. And that's where we have to utilize all our resources, all our allied health professionals, our social workers, our nurses, the clergy, you name it. We need a whole group of people helping most of our people to get well. Now, when you go to looking at depression and anxiety, some of the symptoms can overlap and some don't. When you look at major depression, obviously things like depressed mood, worthless, hopelessness, lack of pleasure, and guilty feelings can come to mind, whereas if you're looking at someone who's nervous, they can be very vigilant, be fearful of enclosed spaces, and have fears of not being able to escape. Could even get ritualistic behavior that's along the lines of obsessive compulsiveness. But the two can also have symptoms that actually overlap. Both depression and anxiety disorders can cause somatization. That's where your body hurts. You have headaches, stomach aches, muscle tension. You can be agitated. You can have bad concentration. A lot of persons whom I treat come in and say, Doc, I've got attention deficit disorder. Well, how old are you? Well, I'm 42. Have you ever had it before? No. Well, you probably don't have just attention deficit. You probably got nervousness or depression. And we delve more into their history, we find out they have elements of both these. And we find out they lost their job, they've been sick for a while. So they don't have ADD, they've got depression or anxiety. And both these conditions cause insomnia. In fact, a lot of persons come in complaining of these exact two things. I can't sleep and I'm tired. And again, they're depressed or nervous. So many things can seem separate, but they often overlap. And you can also have not just depression, but also anxiety or vice versa, or all together. Interestingly, when people go to the doctor and they're really, say, nervous or depressed, they don't walk in and say, Doc, I've got DSM-4, major depression, and panic disorder, treat me. A lot of times they come in and complain of headaches and stomach aches and tense, like we just showed in the prior transparency. 83% of the time they have somatic complaints. So it's our job as healthcare professionals to tease that out, to be the detective, to find that. 17% of the time they come in and say, Doc, I'm nervous or depressed. I'm fortunate. As a psychiatrist, a lot of my patients tell me their diagnosis. Doc, I'm here because I'm depressed. It's easy for me. But those of you who are in primary care, those of you who do therapy, nurses and others, you see people in very complex situations where they don't just tell you their diagnosis. So again, you have to play a detective, and I really respect you for that. To diagnose these problems, you have to have some way to hang your hat on them. Just like when you assess someone, you do vital signs, you do weight. This is how I, as a psychiatrist, assess people, and I stay consistent with it. This is like my vital signs of the brain. We don't have time to go over all of this because we'd be here way past our time, but to just pick on a few, we'll first talk about generalized anxiety disorder, and I created a mnemonic to help you, STGEC, and we're also going to talk about panic disorder and major depression. And these are all acronyms, DCT Caps, STGEC, and I have a relatively simple one for panic to help you hang your hat on the symptoms. So if you suspect someone is panicky or worrying too much or depressed, you can think of it in these terms and it'll help you make a diagnosis. And there's many other diagnoses that play into a person, again, being elderly or even young, who can have PTSD, social anxiety, substance-induced anxiety from alcohol or any other substance. Many illnesses can make many different illnesses can affect everybody. It gets very complex. Now, before we move on, let me just run over the DCT Caps mnemonic. D stands for depression, S stands for sleeplessness or too much sleep, I stands for lack of interest or anhedonia, the G stands for guilt as well as worthless and hopeless feelings and crying spells, E and P stand for energy and psychomotor activity, which are often diminished in depression, bad concentration, change in appetite, either gaining or losing weight, or feeling suicidal. Also psychosis is here as well as homicidal thoughts. And what I do when I evaluate somebody for depression, if they have one of these symptoms, they're depressed and their energy is low, they have no interest, no concentration, they've gained weight, I circle these things. That reminds me that I asked them, that's in my chart. If I ask it and it's a negative, I underline it. Just like with panic, I would write down negative on fear, negative on vertigo, or what have you, so that I know I asked the questions. Again, it's my quality assurance checks. Now, to quickly look at the symptoms of GAD, generalized anxiety disorder, which can afflict elderly persons and as well as anyone else, you have to have this group of symptoms for 6 months or longer. This isn't 6 weeks or 6 days. This is 6 months, of which you need 3 or more of these. These include being sleepless, feeling very tense and irritable, being restless, having concentration impairment, and being tired and fatigued. And most importantly, just like we said at the outset, this isn't just being worried one day. This is where you have a clinical syndrome. These symptoms interfere with a person's life. They're worrying enough to come into my office or your office to seek help. And what I would do is I'd write these down, STIRCT, and I would circle them. So as they come back in the future while I'm treating them and they're getting better, I underline them. That way I know they're getting better, just like watching vital signs for blood pressure. Panic disorder, another very common ailment that afflicts the elderly, includes symptoms of fear. Doc, I feel like I'm dying, I'm losing control, I'm going crazy. And oftentimes it presents as myocardial type symptoms. Needless to say, these persons often have cardiac workups where they are assessing them for having a heart attack. If they find out they don't have any of those criteria met, they have a normal EKG, they have normal cardiac enzymes, maybe it's anxiety, because they have the palpitations, the tachycardia, the chest pain that makes them think they're having a heart attack, but they're really not, but they feel like they are. As well as they have symptoms of vertigo and choking, they feel removed from their body, they tingle, they feel hot and cold. And again, these are bad enough to drive them to the emergency room or my office or your office. It interferes with their quality of life. It's unexplained. They suffer terribly with this. And then back again to the symptoms which we reviewed just a moment ago of major depression. And to be diagnosed with major depression by DSM-4 criteria, you have to have 5 of 9 of these symptoms for 2 weeks or more, of which one symptom has to either be depressed mood or lack of interest. I find a lot of persons will come in and say, Doc, I'm not depressed, but what do you enjoy? I enjoy nothing. I don't like going to the Spurs games anymore. I don't like to go bowling. I don't like to go to church. I don't like to see my grandkids. So you have to ask that question. You can't just ask about the bad mood, because sometimes they'll just tell you, I'm not depressed, but they'll have other symptoms. They're not getting out of bed. They can't attend to things. And most importantly, if they're really sick, they think of not living or hurting others. And again, if there's a positive, I circle it. As I treat them, I underline it as the symptom goes away. And we have to make the symptoms go away because people can have the worst of outcomes. They can die again. If you have no psychiatric diagnosis, we define that as a risk of 1 for suicide. We just chose arbitrary number 1. If you have panic disorder, that goes up to 7 times. You have 7 times the risk of suicide if you have panic disorder. If you talk about major depression, it's a little more risky, 7.9. But if you throw the two together, it's multiplicative. Panic and major depressive disorder, 19.5. It goes up over 2-fold if you have both anxiety and depressive disorders together. So again, you have to ask a variety of questions, both about anxiety, depression, again, looking at substance abuse if you suspect it, because that can cause anxiety, or depression, so that we eliminate this risk of death. And that's important to keep in mind, because 1 of 7 people with recurrent depression take their life. 70% of all suicides are due to depression, and 70% of people who suicide actually see their primary care physician within 6 weeks of death. Now, to kind of shift gears toward the more of a biological standpoint, we'll say here, is I want to put a picture of the brain up. This is what we're talking about today, so that I don't get too esoteric here. When we go to render treatment, whether it's with medicines or psychotherapy, eventually we're affecting the brain as well as the rest of the body. And when we think of it in that terms, different persons have tried to simplify this concept of what really causes illness. Well, you can be born with a problem, neural migration, perhaps that's what happens in schizophrenia. You can have things happen to the brain. You can have lesions. You can have, again, social stressors which affect the brain, but then we have to apply processes to try and overcome that. And we also are doing different things to study the brain, everything from molecular neurobiology, psychology and neuroimaging, electrophysiology and anatomy. We're all trying to get a greater understanding of the great structure of the brain, which I think is the most complex organ in the body. Obviously, I have a bias being a psychiatrist, but it is a very complex organ, and it takes many things to try and get it better. And needless to say, the science of this, the treatment of this, is very complex. And just to think about the neurotransmitters. Neurotransmitters are chemicals that your brain uses to talk to itself. It's a neurochemical, electrical phenomenon. And there are many chemicals involved in that. Everything from serotonin, which we hear about every day almost in the newspaper or some magazine, other chemicals like prolactin, androgens, different chemicals from the gut, which they're working on trying to understand for the treatment of obesity, other chemicals like nitric oxide, which has been popularized with Viagra. So many, many chemicals are involved in this. And the pharmaceutical industry is working with us in psychiatry and the other disciplines to get a handle on these different chemicals and processes so that we can use them to fix the body. And on top of understanding the chemicals, you have to keep in mind that the different systems of the brain, again, the serotonins and the dopamine and the norepinephrine, come from different areas of the brain, and they all interact at different levels of the brain. For example, serotonin. It's involved in the spinal cord, the cerebellum, the brainstem, the limbic system, the striatum, the cerebral cortex. That explains why serotonin is involved in depression, anxiety, sexuality, sleep, and many other things. Norepinephrine is involved in most of these symptoms, and that's why it's important too in anxiety and depression and attention and many other things, as well as dopamine. It's not as diffuse in the brain, we think, but it's likewise involved in many systems. This is important to keep in mind because some people will say, well, doc, how can you give me a medicine to treat my anxiety, but it's also going to treat my depression at the same time? Well, that's because the medicine goes everywhere. It's hitting all these systems. So you can have a serotonin deficit in your limbic system as well as your cerebral cortex. Likewise, you have a deficit of norepinephrine in one of these areas. If that medicine can work on both those chemical processes, it can hopefully fix both problems, provided to a person's attending psychotherapy, going to work and doing other things that are more of an environmental nature so that, again, you get the whole biopsychosocial process going to get them well. Now, this is one of my new creations, just to quickly give you an idea of how complex this can get. Looking at the different disease states, again, in older persons or, again, anybody, unipolar depression, GAD, which we talked about, panic disorder, substance-induced disorders, have different chemicals involved in them. 5-HT is serotonin, NE is norepinephrine, DA is dopamine, gamma aminobutyric acid, GLUT is glutamate, ION stands for ion fluxes, GF stands for growth factors, HPA stands for hypothalamic pituitary adrenal axis involvement, and CCK stands for cholecystokinin. Just to pick on one, to pick on unipolar depression, we think that there are serotonin issues, norepinephrine, dopamine, GABA, growth factors, HPA axis involved. Glutamate and ion fluxes might also be involved. So again, a very complex disease state. Disorder like panic has a serotonin and norepinephrine involved, we believe, as well as GABA and glutamate. If you look at a GAD, it's more of a serotonin and norepinephrine problem as well as GABA and others. There's a lot of overlap here, but again, this is important to keep in mind because if you choose a given drug agent to help somebody, if it can work on, say, serotonin and norepinephrine, which is involved, we think, in depression, but also panic, you could get that person well, whereas if you gave them maybe an agent which just did one thing, maybe they wouldn't get as well. Maybe they'll just get 50% better. So just a way to conceptualize it. This is definitely an oversimplification. There's probably errors in this, but it's one way to think about it. Again, very complex. And I actually show this to patients to kind of to make it not so complex at my desk side when we're trying to make a decision about how to treat them. We've gone through the whole session. 70-year-old lady, depressed and nervous for no clear reason other than the fact her mother had it. She finally got up the willpower to come in. We talk to her, we go over things. Sure enough, she has panic disorder, and she's depressed. That's why she's there today. What I tell her is that there are 3 chemicals that can be involved: serotonin, norepinephrine, and dopamine, and that we need to pick something on top of her doing the right things again, taking care of herself, going to church, but to pick a medicine that can work on these different areas. So in a way, I do act like a shrink. I'm shrinking their problems down. And it's very important to keep in mind, as one who prescribes, that a lot of the things that we do aren't backed up by what's in what's called the physician's desk reference, or the package insert with the medications. A lot of the things on the market were brought to market, say, to treat one thing like, say, epilepsy. But we use it also to treat panic disorder. That's clonazepam. Some medicines were brought to the market to treat depression, like, say, Bexar, but also we know we can use it to treat panic disorder. So as a prescriber, you can choose medicines to do things beyond just what's in the package insert, and the Food and Drug Administration recognizes that. In fact, they make no effort to be the Bible or the standard of care. That's determined in every individual community or the nation as a whole, what a group of doctors or others can do. So again, don't let the PDR or the package insert with medications hand tie you as to what you think you can do with treatment. But do realize that things can be off-label, which is where, again, it's not in the package insert, and you might want to just make note of that in your chart if you choose an option beyond that, just so that you cover yourself medical legally. And when you go to do treatment, there are many choices, and again, we don't have time to cover all of them, but this is just to bring to the forefront and to remind you of them. Here's some medicines that many of us have heard of. The medicines to the far column here are our SRI, our serotonin reuptake inhibitors. It includes Celexa, Luvox, Paxil, Prozac, and Zoloft. Another very important medicine is Effexor, venlafaxine. It is a medicine like these. It has serotonin actions, but it also has norepinephrine actions, and it might even have dopamine actions. Wellbutrin is an antidepressant which has no serotonin actions. It only has norepinephrine and dopamine action. Cerazone is a drug which has receptor properties. It actually blocks a receptor. We also think that it has mild serotonin and norepinephrine properties like these other ones. And then there's Remeron, which is all a receptor drug. It just blocks receptors. So as you see, there's a wide range of these drugs, from serotonin drugs to norepinephrine drugs to receptor drugs. There's older drugs like monoamine oxidase inhibitors, which can be dangerous. People have to watch what medicines they take, what foods they eat, because if you mix it with an MAOI, you can die. Tricyclic antidepressants like imipramine, Elavil, doxepin. Those drugs are actually a lot like these, working on serotonin and norepinephrine, but again, they have safety issues. They can make your heart stop. You can die from overdose. There's also trazodone, which has been around for years, but which really is more so of a sleep aid than a really good antidepressant. And then there's other drugs for conditions, including anxiety and depression, which are our AEDs, our anti-epileptic drugs. That's drugs like carbamazepine, valproic acid, Lamictal, Neurontin. We're all familiar with benzodiazepines like Valium, Ativan, Xanax. There's dopamine agonists, which actually can enhance pleasure. Drugs like Requip. Bromocriptine is an old analog of that. Antipsychotics can be used, particularly obviously in issues like schizophrenia, where people hallucinate or have delusions, any of those disorders, but also in people who have recurrent rituals where they can't stop. Working on dopamine by blocking its actions can help people. There's Buspar, that's Buspirone, which recently went generic. It's used to treat generalized anxiety in the elderly, or again, in anybody. It also can be used as an adjunct with other medicines, any of these, because it actually works at the level of a receptor. It stimulates a serotonin receptor, which we think can make people feel better. And then there's lithium, which we all know is a salt. It's been around since the time the earth was created. It's used for manic depression. It's also used to treat depression and other conditions, but it also can be very dangerous. So there's a wide range of choices, and as a healthcare provider who has to prescribe, I think you have to think about this in a very logical manner, and again, that's why I kind of laid it out like this, because it helps me think about it so that I can pick and choose things that make sense. Like I wouldn't want to put somebody on Prozac and Zoloft, because that's two drugs doing the same thing. But if they're really nervous and depressed, maybe Paxil and Wellbutrin in someone who didn't get well on a single agent would work, because Paxil is a serotonin drug, Wellbutrin is a norepinephrine and dopamine drug, so you'd have all three areas covered like on my graph of depression. So again, a way to think about it. Now to further again show the complexity, again, we don't have much time to stay on this. If you look at a condition like obsessive compulsive disorder, which is an anxiety disorder which definitely afflicts older persons, there's a wide range of drugs which can help them. You can use atypical antipsychotics, you can use typicals, you can use Effexor, MAOIs, Remeron, Cerazone. You can use almost all of these drugs. Now, if you were treating someone for depression, you could use most all these drugs, but again, if you were giving something like a TCA or an MAOI, you'd want to do it cautiously. That's what the C stands for, because they might overdose. Years ago, when psychiatrists had this as their predominant mode of treatment, that is the tricyclics, you would see a patient back weekly and write them a prescription for a week, because if they had more than a week, that might be just enough pills that if they overdosed one night, they would die. And again, all the drugs work at a different level on receptors and mechanisms of the body. And that further includes drugs, again, used for epilepsy. Again, they work on ion channels, many different sites. Now, once you've gone through this long, drawn-out process of trying to diagnose your patient and help them, and finally decide, well, Miss Jones needs a medicine to help her be nervous and get over the depression, well, what do you choose? You'd want to choose her the perfect drug, or he the perfect drug, Mr. Jones. But they don't exist. There is no drug that has the perfect onset of action, is absolutely safe, can only be taken once a day, has no side effects, is active in all, or so here we say a wide variety of disorders and is inexpensive. No drug fits the bill for all of this, but we try. And it's our job as the prescriber to try and pick and choose something that fits all of this. And at all times when you pick something, always put in the forefront safety. I don't like to use any medicines in a dangerous person who's depressed, nervous, suicidal, has even thought of killing their spouse, that they could do that with that drug. So safety, primum non nocere, do no harm. But I also want that drug to get them better. I don't want them taking this medicine for a month and to be no different now and 30 days from now. They've got to be progressing along the way. Also want drugs that have minimal side effects and that they like to take. If they don't take it, it isn't going to help them. And when you're treating older persons, there's many issues which play into that. Dosing, I think if you have to take a drug more than once a day, it's easy to forget. Are you on a bunch of medicines? A lot of persons, as they get older, end up on several drugs. They got high blood pressure, they're on that. They've got arthritis, they're on something for that. Now they're nervous and depressed, they're on something for that. Before you know it, you're on 4 or 5 or 6 things. And because of all the drug interactions and the sites where they work, that can cause someone to get sick. Issues further afflicting there are how fast your body gets rid of the drugs, that's the half-life. When you take a medicine, does it displace another medicine from protein? And again, drug-drug interactions. So many, many variables you have to think about, and again, it gets very complex. And just to remind us of some of the complexities of these drugs, if you look at a drug, for example, like citalopram, that's Celexa, that's one of the newest antidepressants released. It's a drug that has a half-life of about 35 hours, which means it lasts a day, over a day, and days 24 hours. It's a drug that has no active metabolites, but it has high protein binding, which means it sticks to protein in the blood, which means if you have other medicine in your blood, it will displace it. And they recommend no overall dose reduction in the elderly. Now, it's important to keep in mind that as we get older, we lose water mass, we tend to pick up a little bit of fat in our bodies, but overall we're not as big and robust as we were when we were in our 20s or 30s. So typically, in terms of dosing, the amount of medicine that you would give a 70-year-old person should probably be about half of what you'd give someone who's 35. So I do think most drugs you should be a little more ginger with them than just hitting them with a full dose like they were 30 years old, because you can overload them. And then the issues again are whether it sticks to protein, are there other metabolites, how quickly is the drug getting out of the body is important to keep in mind, because again, as we get older, we don't get things out of our body as fast. And if we have more fat tissue than when we were younger, drugs tend to pool in fat tissue. So it hangs around longer. That's important with drugs like Valiums and lorazepam, which are benzodiazepine, as well as other sedating drugs, because once you stop the drug and they're not taking it, they can still have that medicine in their body for several days, and they can still fall, break a hip, and you have to let them know to be careful. And that's especially true of the benzos. I'm not a strong believer in giving older persons a lot of benzodiazepines, and that's all of them, Xanax, clonazepam, Valium, because it makes them tired, sleepy, their motor coordination gets off. In treating anxiety and depression, I'd recommend people to try and use the antidepressants because they cover a wide gamut of neurotransmitters, particularly if you use the more complex drugs like Bexar and Wellbutrin, Remeron, and others, and you can also mix and match amongst all of them, because by doing that, I think you help eliminate a lot of the dizziness and fatigue factors which would go along with the benzodiazepines, and but you can also see those same problems with other drugs too. Anything that makes you sleepy, antiepileptics, you name it. So again, it gets very complex, but always try and think of the great complexity of things, but how to take care of it very simply. And again, looking at mood stabilizers and anticonvulsants as a class, I'm going to just skip over that. And move instead to one of my other creations. I created this back in 2000. I cleaned it up in 2001. And what it is, it's a graph showing the relative problems of these different drugs in interfering with liver enzymes. There are different enzymes in your liver that get rid of chemicals. Now, that's one of your big things of your liver is to get rid of toxins. Well, if you take a medicine that ties up these pathways, and they got fancy names, 1A2, 2C9, 2D6, 3A34, if you take those systems out, whatever chemical is meant to go through it builds up and you can get toxic. Well, in my graph, the worst you could ever get in any box would be 3 pluses 3 times, so a total of 9. Because 3 different sources, Dr. Erachevsky, Dr. Presscorn in Primary Psychiatry, which is a journal, gave different ratings on these things. And when you add it all up, a relative number comes out over here called, and I call this total relative risk. The best risk would be 0. That means the drug has no potential for drug interaction at the cytochrome level. Again, cytochromes are the pathways that destroy the chemicals. The worst you could have would be 3, 6, 9, 12. So the range is 0 to 12. Well, the medicine that fell out the best was the more unusual antidepressant Remeron, 1.33. That's a very low risk. I was surprised to find that Luvox and Prozac fell out the highest at 9 and 7.67. Other drugs like Paxil fell out at 4, Zoloft at 4, Effexor fell out at 1.99, which is very low. And what you can do is say that if this drug Remeron has a risk of 1.33, and I'm giving this to a lady who's already on 5 drugs, that's a safer drug probably than giving her something like, say, fluvoxamine, where it has a relative risk of 9. It's 9 times greater in terms of risk of causing a drug interaction because it inhibits a cytochrome pathway. And I largely use this for, again, for education, but patients like to see these numbers too so that they understand your rationale for choosing a drug. Doc, I wanted you to put me on Paxil. I know I'm on 10 things already. I can understand why you chose Celexa, because it has a risk of 1.6 compared to Paxil of 4, and that helps them understand. Again, all the drugs are different. Some can be bad in one area, not in another, and you have to keep that in mind. But here we're just looking at what is a total relative risk, and the drugs are very different. And just to remind you the different things that go through these pathways, the 3A3/4 system has things like, Cerazone is a substrate of that system as well as an inhibitor. You also have drugs like diltiazem, nimodipine, which are for the heart and the blood vessels. You also have antibiotics like erythromycin. Your androgens, your testosterone, your estrogens go through that system. There's estrogen, omeprazole, acetaminophen, codeine, and then there are things that tie it up. Grapefruit juice actually ties up 3A3/4 system. That's why a lot of hospitals have taken grapefruit juice off the formulary, because it actually causes drug interactions. It also knocks out the 1A2 system. So if you drink a glass of grapefruit juice, you knock out these 2 systems, these things which go through the system build up and you get sick. So for example, if someone smokes a lot and they like grapefruit juice, sometimes they might can feel nauseated after smoking after breakfast because the grapefruit juice inhibited their body's ability to get rid of the nicotine. And then sometimes they say, I quit, I'm tired of smoking, it makes me sick. Also, if you're on a beta blocker, propranolol, and you drink a lot of grapefruit juice, you can get lightheaded and pass out because the beta blocker builds up. So these things do have real life issues with them. Sometimes you give people something intentionally to block a pathway. I'm sure many of you have heard of disulfiram, that's antabuse. That's what we give to people to keep them from drinking. That makes the 2E1 system through which alcohol goes not work right, so they get sick on the alcohol. They feel like they want to die. In fact, you can actually have GI symptoms to where they have to go to the hospital. So you're intentionally doing it there. But you might be not unintentionally doing it to yourself if you're drinking grapefruit juice. So keep that in mind. And once you've diagnosed somebody, decided what you're going to treat them with, thinking about all these complexities, well, how long do you treat them? Well, it depends. I define treatment duration from the point at which they come in and say, Doc, you've made me well. I've been on Prozac now for 2 months. I feel great. I feel as good as I did 6 months ago when I wasn't sick. That's times 0. If they had a mild or moderate depression, I'll probably treat them for about 6 to 9 months. Now, if they were suicidal or in the hospital, I'm probably going to treat them for a year. Now, have they had it for a long time, recurrent major depression? If they've had 3 or more bouts of that depression, they might just need to stay on the medicine because they have a 90% risk of getting sick again. If they've had 2 bouts, it's about 75% risk of recurrence. And again, there, if you're looking at issues of hospitalization and dangerousness to oneself, they might need to be receiving more long-term care. With 1 bout, again, depending upon the initial severity, they may or may not need long-term care. Now, this again is a person who, again, is in their 60s and they've been nervous since their 30s. both with generalized anxiety disorder symptoms as well as rituals of obsessiveness, which lends itself to compulsiveness, they might need long-term care. In fact, a lot of them will tell you, Doc, I have felt the best the last 6 months that you've been treating me than I have for the last 20 years. Can I stay on the medicine? Sure. Because if they're on drugs like antidepressants, anti-epileptics, essentially drugs that are not habit-forming, I'm not worried about them taking those drugs. But if they're habit-forming, obviously you have to worry about that. If they're not safe, you have to worry about that, particularly if they're a lady who's still in her childbearing years. But if someone who's been long-term sick, keep them well. And again, if someone is still in a bad environment that is making them sick, if they are sick, general medically, if they still have bad habits, you want to consider longer-term care and how severe has their illness been in the past. Have they been in the hospital for this condition? And it's particularly important to keep in mind the fact that the dose that gets a patient well keeps them well. And I found a lot of patients over time have, on their own, tried to cut their doses down when they get sick. They do that with their blood pressure pills, they do that with their cholesterol pills, they do it with the pills for nervousness and depression. But it doesn't work that way. Your tissues, your brain, just like your eyes, needs a certain level of help. I see this young guy here is wearing some eyeglasses. You wouldn't think about changing your lens prescription to half of what it is because you couldn't see. Well, if your brain needs the medicines to focus them up to a level to not be nervous and depressed, you leave it alone. So it's exactly the same kind of phenomenon. So the dose that gets them well keeps them well. Treat them at that level until you decide to get them off. And just to remind us that eventually, with whatever medicines we're giving somebody, we're affecting the genome. That's the big talk now, the Human Genome Project. That's because the genes of our body tell our body what to do in the long haul. Medicines eventually affect that. Some of them affect it faster than others. Eventually, we're going to have medicines that are going to go to fix diseases at the level of the genome. That's where pharmaceutical companies are spending a lot of money now. So down the road, we're going to have probably a pill to take to fix a lot of disease states, kind of like, in a way, what we saw in Jurassic Park, where there was parts of the genome that they had to fix to make the dinosaurs. Well, in terms of someone being sick, that missing piece might be a deformed piece, which we would remove with a medicine, take another medicine to put a splice in there to make it right, so that that long-standing bout of anxiety or depression goes away. And in time, I think we'll be able to do that. Always keep in mind that whether you're treating nervousness or depression in an older person or a younger person, whoever, this is the ultimate goal, to be in remission, to go back to a 100% state of wellness. I track that again with the mnemonics, the acronyms I showed you earlier, just like doctors and others track vital signs and weight and other parameters to make sure the body's getting well. I'm trying to make sure the brain is getting well. My goal is to make them be 100% well. It's a challenge. If someone still has bad habits, if they have a very bad home life, if they're unemployed, if they have multiple medical problems, that can be a person who's difficult to get well, but you try. Now, they got to try too. You can only do your fair share. But always, remission should be the mission. Again, remember to track these psychiatric conditions so that you can achieve remission. And I believe that brings us to the end. And I hopefully I covered most of these objectives, teaching you a way with the mnemonics to diagnose and track recovery from anxiety and depression, understand the very complex neuropharmacology of these issues, know there's many treatments, and be able to rationally choose amongst them, to always choose that which is safe and effective. And I think that leaves a few moments for questions. Yes. Yes, because meclizine can be very sedating. So when they take it, it kind of calms them down, but once it's wearing off, they're getting dizzy again. A lot of my patients who have that, I often find out, are having panic attacks, in which case, really solidifying the diagnosis is key. Now, you have to rule out the cardiac issues that go with that. But once you've done that and you feel pretty certain it's not their heart or their inner ear or what have you, then you can choose a good antidepressant, which again in older persons as well as younger persons are really the first choice now for treating these conditions. I use a lot of drugs that do multiple things with one pill. I write a lot of Effexor, Wellbutrin, Cerazone, Remeron, because I tend over the long haul to see more of my patients get well. And that's not to say that Paxil and Zoloft and others don't work. I think they work very well. The problem is my patients have often been sick for years. In fact, I have a group of men who've had panic disorder who've had it since the 1940s after Second World War, and these are men now who are in their 70s and 80s. And for the last 2 or 3 years with us putting them on medicine and combining them very rationally, they have for the first time become panic-free and they love it. Now they can go to the grocery store and not worry about freaking out. Their wife isn't afraid to drive with them because they don't want them, freaking out behind the steering wheel. So they're very happy to finally be well. I wouldn't agree with that. Panic disorder by definition happens for no reason, which means you can wake up in the night with one. Yeah, just for no reason. Now, if you're getting nervous because of driving or because of being in the grocery store, that's more like a phobia, which I think responds very well to psychotherapy. Now, psychotherapy can also help panic a lot because panic's not going to kill you. You might think you're going to die, but you won't. But most of the times you can make the symptoms go away pretty quickly if you put them on an effective regimen, which can often include just only being on an antidepressant, not having to take a benzodiazepine like Valium or Xanax. Oh, yes, ma'am. Do you have a question? I see you talking, but I can't hear you. Can you send your question in because I can't hear you, and then we'll answer your question. Maybe write it down or. Any other questions while she's formulating hers? Well, first I would double check her dose to make sure how much she's really taking. A lot of times we don't give people enough of the medicine. Their body gets rid of it, so it really is doing nothing. So I would get her probably to a maximal level on it, and then if she's still not better, I would think along the lines. See if I can find my chart here. I think along the lines of a drug that does more stuff. And again, if you're looking at treatment options, Zoloft falls into the SRI category, which are really a simple group of drugs in terms of how they work. If you want to go beyond that, I think you would go more this direction. Effexor, venlafaxine, does all that these drugs do, which is serotonin action, plus norepinephrine. We even think in higher doses, this drug might even work on dopamine. Wellbutrin does not work on serotonin, so if someone's really worrisome, it might not be a good choice. And these last two can be very effective too, so there are many other ways to go beyond just staying in the SRI class. And you can also add Wellbutrin to some of these drugs to help. Effexor, you could combine Effexor with these drugs too, but there's a lot of overlap. So I try to spread things out along that continuum. If I can find my graph here again. Here we go. So if you're looking at someone who's real obsessive, we think that's largely a serotonin problem. That's why you're giving her Zoloft. But she's also panicky, and if she's also depressed, it's beyond just a serotonin type problem. So you might want to move again into treating these other neurotransmitters. So it might be well worth looking at her medicine and maybe changing it. So I think Effexor, Cerazone, Remeron would be good drugs to consider, maybe even if you wanted to, and there's a reason, add Wellbutrin so that you get more of these neurotransmitters treated. Any other questions? Did we ever get her question? PET, positron emission tomography. That's really just still considered research type evaluation. I know of no places beyond the Health Science Center where they use it in research protocols can you have that, and I don't know of anyone who just does them for diagnostic purposes. They're still very research, experimental, right, research oriented. Oh, it has many. It would probably have difficulty getting on the market now. They tried to market it because of some of those issues, but all the drugs have an Achilles tendon. Yeah, it's big, but it's probably no worse than a lot of others, like aspirin and aspirin, penicillin. I mean, they all have a weakness. Well, any other questions? Do we ever get the lady on the television there? She'll send it in. Okay, ma'am, if you would just send your question in. Well, I guess that's it. Thank you.